Great. I'm John Condie. It says John Condie. I also go by Johnny Condie. I've been with St. Luke's Neurology for 8 years. Before that, I was at Phoenix Children's Hospital Neurology Neurocritical Care. And that was my first job after training. So one of the three child neurologists at St. Luke's, and I would estimate that epilepsy is about a third of our cohort that we see. So I am filled out more seizure action plans in the last 8 years than I think is countable. So I know this well. Okay, I guess I'm on. Nobody pays me anything except the hospital, so I don't have any disclosures. So welcome to the rabbit hole that is epilepsy. There's obviously no way we can talk about everything. So I kind of broke it down into these 5 major objectives. We're going to try and review the major different types of seizures. Now, we're not going to get to all of them. I have an anecdote here that when I was doing my training in Chicago, I was working with Doug Nordley, who was at the time the president of the International League Against Epilepsy, who was also working with Ann Berg, who is one of the top epidemiologists in the country. And they put together this new proposition on how to classify all the different types of seizures. And I was with them, and I even helped a little bit, and so it made sense to me. And then the funny thing is as soon as it was put out to be implemented, that's when I took my first job in Phoenix. And when they reviewed it in the room full of epileptologists and neurologists, there was mutiny. They were saying, this is too complicated, this is too detailed. I cannot remember all 76 types of seizure classifications. So the point is that this is a rabbit hole that you can go very, very deep in. So we're not going to go that deep. We're just going to talk about the major parts. Now, not all seizures need to be treated as urgently as other seizures, and it can vary from seizure type and it can vary from person to person. So I wanted to touch base on some of the critical thought that needs to go into many of these kids with epilepsy. Almost as important as the critical thought is understanding the students, because they're all going to be different. Right now, there's pretty much 4 major types of different abortive interventions. Not all of them are medications, so we're going to talk about that. The next one I understand is kind of a hot topic: when to activate EMS and when it may be okay not to. Now, this will be coming from my experience as a neurologist, and I certainly do not want to contradict school protocol, so we can maybe open that up at the end there. And then I really want to give a brief mention of what are called psychogenic non-epileptic seizures. This has sort of become a rather endemic kind of a phenomenon lately. And if you haven't seen one, you're going to. So I'll end with that. Okay, next slide, Jocelyn. All right, a couple interesting facts about epilepsy. So about 1.5% of children have epilepsy, which is defined as having multiple unprovoked seizures. And about 4% of children will have at least one unprovoked seizure in their life. So not every seizure leads to epilepsy. Well, one misconception out there is that seizures are a medical crisis. And that is not usually the case. So death due to a seizure in children is very rare. We call it SUDEP. And there are some risk factors that make it more common, but even with all of the risk factors, it is very rare. Most of the time, a seizure, there is time to think, there is time to relax. It's not an immediate life or death situation. Now, the good news is that about 50 to 80% of children are expected to outgrow their epilepsy, which means that if a child starts to have epilepsy pre-puberty, we are quite optimistic that by the time they get to 16, 17 years old, we can have a good 3/4 of those children off their medication, and the seizures will not return. Most common cause of breakthrough seizures in children is they don't take their medicine. So that's an unfortunate reason why you're going to be seeing some of these seizures in school. It's because parents and children are not compliant. Now, the other interesting thing is that, and this is very important for the 504, is that learning and cognitive difficulties are more common in children with epilepsy, even if the seizures are fully controlled. So we have a neuropsychologist at St. Luke's who runs our neuropsychology testing in children with epilepsy, and she has made the claim, in her world, once you have epilepsy, you always have epilepsy. Even if you have outgrown the seizures, even if the epilepsy is not a problem, she is still finding 5, 6 years later that these children have some special learning needs and some special academic things that need to be addressed in school. So that's kind of my introduction to epilepsy. Next slide, Jocelyn. Okay, so this is probably review for most, but if you wanted to take a 30,000-foot view of the different types of seizures, we break it down into these 4 types. There's the generalized seizures. Now, generalized seizures, those are given in Hollywood. Everybody has a generalized seizure. If you have epilepsy, you have a generalized seizures. Those are the very dramatic, fall to the ground, convulse, often foam at the mouth. That's when you'll bite your cheek, bite your lip. Many times you lose bladder continence. Then there's the most common type of epilepsy, and that's childhood and juvenile absence seizures. And that's the one that's pretty classic for just, they think students and parents have just been thinking the child's been daydreaming, staring off, being unresponsive, but in actuality, they're truly having a seizure. Myoclonic seizures, the best way I can describe those is, imagine if a brief electrical shock went through your entire body once. So very, very powerful, kind of a shudder. And then there's the dreaded atonic seizures. And atonic seizures will take an upright student and drop them to the ground faster than they can react. So many times if a student with epilepsy comes to school with a helmet, it's because they suffer from atonic seizures. And without the helmet, they would get traumatic brain injury lacerations on their face. Now, focal seizures, coming from a particular part of the brain and staying in a particular brain, this is where seizures can get very interesting, and we're going to go over some examples of this in a bit. So I've heard some teachers say, oh, I've been teaching for 10 years and I've never seen a seizure. I'm skeptical. Let's just say I'm suspect, because some of these focal seizures can be pretty subtle, and it could quite be that some of these children are having brief multiple seizures in your classroom and you're just not recognizing it. So we'll kind of go over some of the tells of the more common focal seizures with videos in a bit. Now, complex seizures, those are focal seizures that tickle your awareness centers in your brain. So you will notice, or you will see, that they are unable to interact with you and the environment appropriately. There is a definite cognitive clouding, if not a complete absence of interaction. And then the last one, the secondary generalization, I bring this up because it's going to be very important on when to treat or when not to treat. And these are some seizures who start out as focal, and they can remain focal for seconds to minutes. And then over time, the seizure field spreads and goes to form the convulsive generalized seizure. So quick overview of the 4 different types of the way that you can think about it in your class. All right, next slide. All right, so I've got some examples here. These are all examples from the American Academy of Neurology, and they have clearly given their permission for these to be published. These are on an academic article's website. So this is the first seizure, and it's going to kind of show you there's an EEG running, and this child is now seizing. So what you notice is that the blink has stopped completely. I don't know if you can appreciate it, but there is a look in his eyes that the lights are on, but nobody's home. So this is what a typical absence seizure will look like. This particular seizure happens to be a complex partial, but sometimes they're indistinguishable. And now there's going to be a very subtle focality. So one might consider that in the class as, oh, he has a motor tic, because in this particular age and gender, motor tics are much more common. And, you know, he still is kind of clouded there, and you can still kind of get his attention. And now seizure's over. So that was a very classic subtle focal seizure. And again, if you haven't seen hundreds and hundreds of seizures, or you don't have a high level of suspicion, that type of seizure could easily fly under the radar as being just a behavior or a complex motor tic, or maybe just a daydreaming. All right, Jocelyn, next movie. Same thing here. This is a classic focal seizure. I'm not sorry. This is a very focal seizure. I'm not going to say it's classic. One might just think she's got some eye spasms. She doesn't look particularly uncomfortable. She doesn't look particularly altered. But if my eye is going towards her hands. We call those mannerisms. She will do some pin rolling things. She's got that rhythmic blinking of the eye, and then her hands will kind of move almost like a stereotypy or another tic. And then another pretty dramatic and hard to watch seizure. This poor gentleman, he has repetitive vomiting with his seizure. That's really the only thing that it does. The EEG there is proof. The red lines are the right side of his brain, and you don't need to know it, but he's having a very focal right temporal seizure right now. He is fully unaltered. The nurse is talking to him. He's answering questions, but he just has repetitive, violent, ictal vomiting is what we call it. So I bring those up because when should you get suspicious that your child in your classroom might be having seizures? Well, seizures are very stereotypical. They often look like the last one, and the next one will look like this one. Look for sometimes subtle but present alterations in consciousness, sort of a clouding, sort of a decreased time to respond. And there's after a while, there's a look in the eyes, like I said, there's a glazed, often fearful, often just absent look in the eyes. And it certainly is easy enough to rule it out. The wonderful thing about working up seizures is there is no risk. The EEG is a safe, painless, and relatively cheap way of answering that question. So beware of the focal seizures because they can be quite subtle. All right. Okay, some important facts to know about what a seizure might do in your class. The vast majority of the seizures are self-limiting and will stop by 5 minutes. But if the seizure continues past 5 minutes, statistics show that the chances that it will stop by itself starts to decrease significantly. So that if a seizure hasn't stopped by about 10 minutes, it's almost certain that it's not going to stop unless there's some pharmaceutical intervention. If the seizure has been going on for about 30 minutes, there are actually changes in the neurons and their receptors that make the seizures more resistant to medications. If a child has a history of having a single prolonged seizure, then there is about a 50% chance that the next seizure they have will also be prolonged. So please store that one away in the memory banks because that's going to be important later when we talk about who and when to treat. On a similar note, if a child has a history of having focal seizures that frequently generalize, then again, that next seizure that they have has a high risk of generalizing. So we're going to talk about why I'm emphasizing that. And then this scares everybody. Every child who has a convulsive seizure desats. And it's okay. We have an epilepsy monitoring unit. We bring the children in. We need to learn more about their seizures. We take the seizure medications away because we want them to have 3, 4, or 5 seizures. And we will have them on video and full monitoring when they have their seizures. And we will usually say give oxygen if the SATs drop below 60, and we almost never have to give oxygen. So I say that because very, very few things triggers the panic state in seeing a child turn blue, seeing the cyanosis around the lip, not seeing any productive breathing. And I do want to reassure you, I don't by any means want to say don't take that lightly and don't continue to monitor it. But I just want to reassure you that in our experience and in our unit, every child with a convulsive seizure does that. And in the end, the brainstem will kick in and the need to breathe will kick in and will eventually overcome the seizure. So there has been CPR that has been given numerous times by bystanders, by parents, by teachers. Probably wasn't necessary. The best way to bring the child out of the cyanosis, out of the out of the disorganized breathing is to stop the seizure, which we'll talk about. All right, next slide. Okay, so when I was starting neurology, I had an attending whose favorite sort of catchphrase was, we need to beat the don't just stand there, do something out of you, and beat in, don't just do something, stand there. Because that is often harder to do, especially in a seizure, than jumping on and feeling like you have to do something. Okay. So there are situations where you can recognize this child is currently having a seizure, and I don't need to treat it. And the big one are the absence seizures. Absence seizures do not hurt the brain. That is one of the most fascinating phenomenon to me, because when I am looking at an absence seizure on the EEG, it looks god awful. I cannot tell the difference from that in any other seizure. But studies have shown in neurometabolic follow-ups and PET scans and everything else has shown a child can have an absence seizure. And I'll tell you some anecdotal stories in a bit, for months, or I'm sorry, for hours to days. And then you stop it and immediately they return back, and there is no depression, there is no lethargy like you would expect. The markers that show brain and neuron injury are not present with absence seizures. So there's time. You don't have to necessarily treat absence seizures. The other condition is focal seizures that do not generalize. They're many times parents are, a great example is recurrent deja vu or recurrent smells, or like you smell something but it's not there. It's often a burning smell. Those are temporal lobe seizures. And I will get somebody in my office and we will realize they have been having these temporal lobe seizures for years and they've just never generalized. Now we'll want to get rid of them, and so we treat them in the office, but if their history is that they stay focal and they've never generalized and that they've always been 2-3 minutes and brief, you don't need to worry about treating those. And the other is the myoclonic seizures, the shock-like seizures. Those are so brief that unless they're clustering, unless they're having 3, 4, 5 an hour, they're not something that you have to jump onto. So those are the 3 instances where I would say, don't just do something, stand there. On the opposite end of the spectrum, I'm sure any of the school nurses who has ever had a seizure action plan in front of them is very used to the go ahead and give if the seizure has not stopped within 5 minutes. Well, on the other end of the spectrum are these particular situations where you do not wait for the 5 minutes. And if you get the seizure action plan and it implies you wait for the 5 minutes, I would say that is a reason to call the neurologist or the provider to say, are you really sure you want me to? Number 1, and we're going to kind of circle back now to one of our previous slides. If that child has a history of status epilepticus, if that child has ever been hospitalized before because the seizure went on for 20, 30, 40, 50 minutes, there is such a high percentage that the seizure that you are seeing in your classroom is going to go on to become that status epilepticus, that it's not worth the risk to wait.
Door mount kit into position.
That was not me. And so in that situation, because we know that there's a high percentage it's going to go on to the prolonged seizure, and that seizures become less resistant the longer it goes on, that's a horse you want to get in front of right away. You do not want to let that horse out of the barn. So the seizure action plans that I give will often say give at the immediate onset of the seizure. And one reason for that is because the child's history of status. The second, if there is a history that the seizures have severe autonomic dysfunction with them. And what do I mean by that? Well, there are apneic seizures and there are asystolic seizures. There are seizures that will cause the child to stop breathing, and there are seizures that will cause the child to have large pauses in their heart rate. So not time to wait for 5 minutes. The best way to treat the apnea and the best way to treat the asystole is to stop the seizure. So because of the severe involvement of the autonomic system with those seizures, time is of the essence, and you will want you will want to get to know those kids because those will be ones that you need to jump on the seizure right away. And finally, this one's a little controversial. This is my 2 cents. If you have a child who starts out as a focal seizure, and they often, if they nearly always go into the secondary generalization, why put them through that? So if they've got 2 or 3 minutes where they are doing a facial twitch, or they are looking off to the side, where they come to you and say, I've got that feeling, I've got that taste in my mouth, or that smell in my nose, or I'm having deja vu. And 9 times out of 10, that's a sign that in 5 or 10 minutes from now, they're going to go into a big convulsive seizures. My mantra here is that seizures suck. Sorry, they do. They are awful to watch. They are awful to experience, the convulsive seizures. They're often associated with very embarrassing things for that child, urinating or sometimes defecating their pants. They're going to probably end up in the ER. The post-seizure brain dysfunction and recovery time is going to knock them out of school that day and perhaps the next one. And if you have this time window where you're like, I know it's not 5 minutes, but if I can prevent that from happening, and instead of all of those consequences and complications, I'm going to give this medication with a proven safety and efficacy record, and I'm going to keep this seizure to just the weird smell. To me, it seems from a empathetic and humanitarian provider that's the best thing for the child. Every time I go over this with the family and say, hey, look, I'm going to break protocol with you at home. The pharmacist is going to tell you you need to wait 5 minutes. I'm going to say, as soon as you get that deja vu, you give it. Every time the family has eagerly done that and has been very, very appreciative that they are preventing the big seizure instead of waiting for it. Jocelyn, did this just pop up? Participant has enabled translation.
Yep, that has not happened before. We'll just click on save and we'll figure that out in their back end.
Okay. Okay. So pretty much for all other situations, you usually give them the mandatory 3 to 5 minutes to let the seizure stop by itself before intervening. Now, one thing I will usually tell is it seems to me pretty barbaric to say, okay, you stand over the child watching them seize with the stopwatch, and you like you're clocking the Kentucky Derby, and say now. So what I often tell parents in schools is you have somebody calmly walk to where the medication is, take it out, take a deep breath, bring it back, take it out of the package. That's going to be a minute and a half, 2 minutes. And so then after that, if the seizure is still going on, you're getting pretty close to the 3 to 5 minute mark, and you might as well just go ahead and give it at that time. All right. Next slide. All right, let's talk about the particular things that are out there. So there are 2 intranasal abortive interventions right now. One is called Valtoco, and the other is Nasolam. Valtoco is intranasal diazepam, Nasolam is intranasal midazolam. We can give Valtoco for any child 6 years and older, and Nasolam for 12 years or older. Valtoco, it's very dose dependent on the weight. So it may be 1 dose per nostril, it may be 1 dose in both nostrils, it may be 2 doses in both nostrils. It all depends on the weight. Okay. Nasolam, however, is not weight-based, and so it only comes in 1 5 milligram dose. So Nasolam is easier to remember, but unfortunately, it's not available right now for children under 12. Okay, so the most common mistake is you're too gentle. I'm too gentle. You got to stick this thing all the way up the nose. So you can see that you've got the main port there where it goes up the nostril. The best thing to do is to put your index finger and your middle finger on both sides of that, and then you stick it up until your fingers are physically contacting the skin of the nares or the nostril. It doesn't just go in a little bit, it's got to go all the way up there. Your intent is to spray this thing in the sinuses, not just keep it in the nasal cavity. And that's really, other than that, these things are mistake proof. They're so easy to give. It's really easy to get access to the nostril. And we are currently flooding the market with it, and I've not had any bad experiences with it yet. All right, next slide. All right, the rectal version. So this is currently what we have available for children under 6, and it's Diastat. It's pretty self-explanatory. This goes in the rectum. You push this all the way up into up to the skin, and then you have your plunger right here. So this is actually more effective in side-by-side trials than the nasal sprays, but the efficacy of the nasal sprays actually is more practical than this because, as we talked about, the longer the seizure goes on, the harder it is to treat. Well, because the nasal sprays don't require any kind of prep, and you can literally just pull it out and give it. You can give the nasal sprays a lot faster, whereas diazepam, you have to access the rectum. You have to make sure and put some lube on the tip there. And people, because of the adrenaline of the situation, they make the most common mistake, and that's they push it in too quickly. It's like a stat push. Well, you do that, you're going to expand the sensory receptors in the rectum, and it's just going to push it right back out at you. So it's recommended to take at least 5 to 10 seconds. So you count to 10 and slowly push it in. And then when it's in, you want to do another 5 to 10 seconds of physically, pushing the cheeks closed to prevent expulsion of that out of it. So Diastat is not the easiest thing to give. Technically, it's the most effective, but in reality, it probably is not because of all of the hurdles on getting it in a timely and effective manner. And the next one. All right, so clonazepam. Sometimes this is all we can do, right? If the child is not a candidate for a nasal spray, maybe they've had a bad experience to the Diastat. Maybe they're 17 years old, and when they have a convulsive seizure, they are just too physically overwhelming to get access. And so the last option is this clonazepam oral dissolvable tablet. It is the least effective, but it is also the most convenient because it's just a tablet. So the instructions say place pill under the tongue to dissolve. Good luck. I don't know if anybody's ever tried to access the sublingual part of a patient in a clenched convulsive seizure. I would not recommend trying to do that. You're putting your finger in danger if you can do it. And most of the time, the seizures are so powerful in the jaw that you're not going to be able to get the mouth open. Just as good as if you can get it between the cheek and the gum. So you do not have to put it under the tongue like a sublingual. Like I said, suboptimal, but better than nothing. So usually when we have prescribed this, it's because the other two forms are inaccessible or contraindicated. And finally, the non-pharmaceutical. Next slide. Many children will have what's called a vagal nerve stimulator, or VNS. And for many of those children, they will have with them on their personage this magnet. And the way that the VNS works is that usually under the left clavicle area, so it's usually somewhere around here, there is a generator. And every 5 minutes, that generator sends an electrical impulse up to the vagal nerve, retroactively sort of giving this pulse to the brain and acting kind of like a pacemaker for the brain. And in some of those children, taking that magnet and slowly swiping it over the generator, 1 to 2 seconds, what that's going to do is going to cause the generator to give a stronger and more prolonged burst of electricity to the vagal nerve. And for many children, that is an effective seizure abortant. And it's a great way if it works, because there is no downtime, there is no benzodiazepine sedation, and they can get right back to their cells. Now, obviously, because this is not a medication, there is no reason to delay it at all. This is more effective if given early on in the seizure. Many times children with Partial seizures will feel the seizure coming on and they will swipe it themselves. But if they don't and you have access to it, there is absolutely no reason to pause treatment at all. This is safe, can be effective, and it is without any medication side effects. Okay, next slide. Okay, so to EMS or not to EMS. Now, okay, yeah, so we did change this a little bit because of that last bullet point. We wanted to make sure we follow your school's district protocol for acting in EMS. But I would say that these are the times when there's no question. If two rescue medicines are needed, so we can talk about, I will just say at home, I tell the parents, and it's pretty common practice, if they're at home, because these medications have such an effective and safe track record, and they have to give a Valtoco or a Diastat or a Nasolam, and that stops the seizure. Those parents usually do not take their child to EMS. We can, again, pontificate on whether or not that's appropriate with your school's protocol, but definitely if the seizure does not stop after 2 or 3 minutes of giving the dose, that's a hint that it's going to need to go on and get IV rescue. If you're not sure whether the patient has stopped seizing, and this can be very difficult, but one way to, or I guess some of the things that would worry you that the child is still seizing, even if the convulsions have stopped, look for if the breathing is still disordered. If they are unable to follow any kind of command at all, usually when a seizure has stopped, there's a sort of final deep gasping breath, and then they will take on a very appropriate, regular, and physically normal breathing pattern. So that breathing pattern can be a tell sign. If they're still doing shallow, irregular breaths, but they're not convulsing, they're probably still seizing. When in doubt, activated EMS. Obviously, if there is a witness head trauma, now you have 2 reasons to go to the ER, concussion and seizure. And then finally, each school may or may not have their own protocol. I certainly do not want to say that this lecture supersedes your school's protocol. So follow your school's protocol or your district's protocol. And now I think I got one more slide to talk about. Okay. So there is an entity called psychogenic non-epileptic seizures. And this used to be rather uncommon, but now it is unfortunately gaining a lot of, I don't want to say steam, but it's getting more and more common. Psychogenic non-epileptic seizures are exactly what the name says. They are abnormal seizure-like movements that are rooted more in mental and psychological trauma, and they are not epileptic in their origin. So when a child has a psychogenic non-epileptic seizure and we have the EEG on them, they will thrash and they will thrust and they will spit and they will do all sorts of moves, but yet the EEG or the electroencephalogram stays perfectly normal. Why do I want to bring this up? Well, you don't need to treat. If you know the patient and you know their chart and it says PNES, PNES, or they have diagnosed with PNES, or maybe they might, well, we'll go back to that. This is a situation where less is more. So, number one, psychogenic non-epileptic seizures do not hurt the brain. They can go on for hours and hours and hours, and the brain is fine. Number two, self-preservation remains intact. So somebody with psychogenic non-epileptic seizures will not drown. They will not crash their car. They will not fall off high buildings. They still have the awareness that they need to protect themselves. And then the third thing is because this is rooted in an emotional and psychologically traumatic event, and you're dealing with a very fragile psyche, the more you convince that patient's subconsciousness that there's something wrong with them and that they have epilepsy, the more they're going to believe that they have epilepsy. and then the more they're going to have these seizures. So every time one of these children gets taken to the ER, and then the ER says, "Oh my gosh, they're in status," and slams them with drugs, and admits them to the ICU. Every time that happens, the subconscious of that child, it gets confirmed, I have seizures. I am a difficult to control epileptic. And then the neurologist comes in and tells them, no, you don't have anything. Well, they're not going to believe us. They're going to believe their own intuition. So you really want to minimize the amount of attention that you give this child who is having a psychologic non-epileptic seizure. It's okay to leave them alone if you're sure that's what it is. It's okay just to have them go to the nurse's office and move around, and every 5 minutes just say, "You doing okay? You out of it? Nope. Okay, well, I'll check back in 5 minutes." That is actually, as sadistic as that may sound, that is actually how you help these children come to grasp with the fact that they're not epileptic. So if you're positive, if you've talked to the neurologist, if it's in the record, many times the parents will also say, yes, my child has psychogenic non-epileptic seizures. Again, less is more, and medicine is not needed. Are these sometimes called pseudo-seizures? Yes, they are sometimes called pseudo-seizures. Just like everything else, the nomenclature of neurology changes, and so now what used to be called pseudo-seizures are now called psychogenic non-epileptic seizures. So same thing. Good question. Okay, well, with that, I think that's my last slide. I was told I had 30 minutes and I took 37, so pretty close. I'll take it. And I understand we're going to have a case presentation, and I'll stick around for any Q&As afterwards.
Yeah, let's just move into questions right now from the presentation, if you don't mind.
No, I don't mind.
If anybody has any, feel free to unmute, or you can type those in the chat and we can read those out loud. Anyone have questions?
Will anti-seizure medications stop pseudo-seizures as well? Nope, they do not. I mean, let me put it, if you snow them with benzodiazepine so they fall asleep, it will stop the psychogenic seizures, but they do not actually treat the non-epileptic seizures.
I had a quick question. It's a little selfish. I'm in diabetes world, but what about hypoglycemic seizures? Does that lead to any reoccurrence of seizures or increase their risk of getting seizures?
So it can, yes. Boy, you went down that hole. So the hypoglycemic seizures, it's a double hit for the brain, because the reason why the brain is seizing is it doesn't have enough energy to establish the appropriate equilibrium. Now, why nature did this, I don't understand, but there are these neurons called interneurons that need glucose more than the rest of the brain. And the interneurons are inhibitory. So the first neurons that are going to go quiescent or silent in hypoglycemia are the neurons that are majoritively inhibitory, so they're going to provoke the seizures. So it's this cruel truth that when your brain runs out of energy, it's going to do something that requires 4 times more energy than usual. So now you don't have energy, but you're forcing it to do a highly energetic activity. It can lead to metabolic scarring, and it can lead to more of a what we call symptomatic epilepsy, that you've actually hurt the brain, so now the brain is going to have more seizures. But that's a case where if it's hypoglycemic seizures, those are often resistant to seizure medications. You need the glucose. So I didn't even touch on that one.
Thank you. There's a couple questions coming in the chat. I'm not sure if this last one's a question. Shannon Kessel, was this a question or just?
Can you speak to the point you made about pharmacists giving contradict? Yeah, so I mean, pharmacists don't have the luxury of spending hours and hours and evolving with the patient, right? They have this prescription and they have protocol. So it's very hard for pharmacists to individualize the treatment to that personal patient. Now, epilepsy is a very personal disorder. You can have the same gene in two brothers, and their seizures and their complications will be vastly different. So, the protocol that the pharmacist will get is, okay, you are to give this medication if the seizure has not stopped in 5 minutes. And so many times when we say you need to give this medication at the onset of the seizures, that is against their protocol, and we'll get a nasty phone call from them. Or it's not always nasty, just we'll get something requiring explanation. And then when we tell them why, they usually understand. But it's important to individualize the treatment for the individualized person and their individualized epilepsy disorder.